Hello and welcome to our June 18th Gateway Rotary meeting. I am going to see, I think it's up Pat here. She's going to give us the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic which stands one nation under God, indivisible, with liberty and justice for all.
And of the things we think, say, and do, number one, is it the truth? Number two, is it heretical concern? Number three, will it build goodwill and better friendship? Number four, will be beneficial to all else.
And we have Jenny here today. So is Jenny here today? I haven't seen her walk in yet. So she is our inspiration. So I don't see her inspiration here today. So I always have a couple of extra quotes just because of who I am. And yeah, I love to go through inspirational quotes. So I have something here and I'm going to read off. This is one of my thoughts for the day. Love is often romanticized, but at its essence, it's the first language of the heart. Babies recognize it in touch before they understand words. Lovers share it in silence, more powerful than speeches. When quotes speak of the hearts, they remind us that it isn't always grand gestures, but the quiet consistency of the heartbeat that matters. So we'll start off with that, and that kind of leads us into where we're going to go today. But first, I'm going to introduce some of our visitors, some of our home club visitors. Welcome, Jennifer. Oh, yeah, thank you. I will let Beth Laura introduce our visitors.
My guest today is Jennifer Philippi. She's also a member of the Cape Pension or Illinois Valley Club.
We also have, let's see, we have another guest. I'm sorry. We also have our speaker. So the speaker will be introducing our speaker. Let's see. Steve Rowe has his lovely, Peter, want to introduce who our speaker will be quickly?
Well, I'll do it better. I'm Peter Angstead from the Wednesday Club, but our speaker will be Dr. Brian Rose, and I'll tell you more about him in a little bit.
I want to introduce you because you're a guest as well. Okay, and then we have, let's see, Steve has this very special guest today.
Christy, my wife, is here today.
All right, nice to see you. Thank you. There you go. Okay, so I think we've got it there with our guests today. Let's see, I have a couple of announcements. Did we tack it? Did we sell all our cards?
No, apparently I am the worst illustrator.
No, but that's okay. He's got all sorts of them. So he's just, no, you're not feeling. Just you get a chance to walk around and remind people and beg for dollars. So that's great. So we'll let you do that. Okay, I have an announcement from the Friday Club actually. This June 27th at Lake Selma, Siskiyou Folk and Bluegrass Festival is going on, and that is a Cape Junction fundraiser. Fork in the Road, Hula Onuka, Ayana, Americana, Borderline Music, Quartz Creek, The Anthill, The Dangerous Lee, and Rattlin' 3 with MC Cousin Keith and Slughouse Sam. Tickets are 25 per person at the gate, $5 to park. Gates open at 10 a.m. and there's music from 11 to 6. So bring lawn chairs, blankets, family, and friends. Please, no dogs or outside alcohol. So we were asked by Bruce to bring that to your attention. Also on the tables, there is the Friday Club I don't know if it's Friday or Wednesday Club, but they're doing a fundraiser for the 4th of July. And I've sent it around twice. And so we have a few people who signed up. It's music. It's a fundraiser for the Fork, which is for the food bank. So it's a fundraiser for the food bank to raise money for kids. And it's July 4th from 5:30 to 7:30. And so I will send this around. If you want to write a check, you can. It's $40. It will be $45 at the door. And they're asking you to order ahead of time if you want food there. So I'm gonna send this around one more time, and then I'm gonna turn it in. So if you're interested in going, please sign up. I'm looking for the pins, which of course, I don't see any pins here this time, so I will find one in my purse. But I'll send that around if anybody's interested in signing up for that, 4th of July. And if you're still going to the fireworks, it's between 5:30 and 7:30, so you still make it back and watch the fireworks for the city celebration. All right, other announcements. I don't know if anybody wants to make an announcements about Porch Fest. That's this Saturday. I know Jenny's here, but I don't know, is Doug or anybody here who wants to make an announcement about Porch Fest? We all know we're on. We're meeting, yes, go ahead. 9 o'clock, we're meeting 9 o'clock at the,
That's the staging area.
yes, that is the staging area. So if you've ever been there, it's Manzanita, it's at the end of one of the, and that's where they do the staging and everything, and we have to hand out all the signs and get them around for the musicians. So, okay, with that, Jenny, thank you.
Thank you. Sorry I'm late. I ran into every traffic obstacle possible on my way here. I was the inspiration person today. So I'm gonna, speaking of Porch Fest, I'm gonna throw that out there. Music is the great uniter, an incredible force, something that people who differ on everything and anything else can have in common. Which takes me to my announcements. We had our president's meeting last night, and there is a lot of conversation about a very big fundraiser with all 4 clubs. There's a lot of moving parts and a lot of questions, and we've made a lot of progress, and I would like to update everyone. And so what we're going to be doing is we're going to be having a Zoom meeting on June 29th, 5:30 p.m., which is a Wednesday. They'll be doing a presentation. Dan Converse, am I wrong? Brad Converse has done a lot of work on this. He's going to be meeting with the Wednesday Club and presenting for them. And then we're going to have a Zoom meeting that night from 5:30 p.m. on. There'll be more information about it in the Navigator and upcoming. But please think about the questions that you might have and the commitment that you may or may not be willing to give, because we'll be making a vote on that as a group in August. And I've gotten some input, but I really want to get everyone's input before we make a final decision. So thank you. Suppose I could give you more inspirational things.
Okay, anyway, so that's a big thing, and we're really hoping that you can think of questions that you might have, doubts, things that you're questioning right now. It's looking at Reinhardt, which is where we really want it to be. It's got to be in town. So if you have lots of questions, we're hoping to get those questions to Jenny, myself, so we can get them to Brad so that he can answer a lot of questions that night. And we're hoping to get a yay or a nay in August, because if we do decide to go forward with it, there's, it won't be till 2027, so it's not going to be this year, but there's a lot of things that it will take to get it up and running. So that's, are they bad? The project is the Christmas lighting, a Christmas tree event. So lighting the trees and building a Christmas tree lighting in Grants Pass. That is what they're thinking about. We've had a steering committee. They've gone kind of roundabout looking for places to do it. They were looking first out at out in the county, and we said, no, nobody will ever drive out into the county for this. It's got to be right here in our town. So right now, Bob Brunel is looking at, and Tom are looking at Reinhardt. We were told from Pacific Power that they have enough power out there to do it. We just need to make a few adjustments. The city may need to put a little bit of investment out there, to minor investments, to be able to run it. The active club said they'd help us with some of their electrical that they run for Boatnick. So it just looks like something big. We used to raise with the Duck Derby used to raise $100,000 in grants for the community, and that's been missing. We don't have anything like that all Rotaries came around with. So they've been trying to put together a steering committee that said, let's think about it. Can we do something? And what they've done, and Brad Converse has put together this business plan. And the biggest thing about it is trying to get as many community organizations as possible to do it so that it's not just a drain on Rotary, and to let kids organizations actually man it and run it so that we're not as old Rotarians having to be out there every night. So he's really kind of looked at all those things to try to make it happen. So that's where we're at. Okay.
Be a fundraiser?
Yes, that's the whole idea, is to be a fundraiser. So to get sponsors, to get sponsorship for it, and then to also charge for people to go through the park and see and have, you know, Santa Claus, the whole thing. They have one in Brookings, they have one several places, but they don't really have one in our valley. And so it's just a way of saying, try to get something away from summer. Because right now, summer is so with fundraisers that it's just like, let's see if we can get something to happen another time of year. So stay tuned. There will be more talk about that meeting. Keep your questions so that we can ask them there. Okay, with that, further ado, I'm going to have Peter Angstad come up, in my best to my German Angstad to come and introduce to us our speaker today.
Thank you, and I'm Peter Angstad. I'm just unemployed and don't work anymore. Anyway, I was very honored to be asked to introduce Dr. Gross. He and I have been friends for several years now, ever since our service on the Asante Board of Directors. He's still on the board. They asked me to leave. So anyway, if you read the email sent out by Steve Rowe yesterday, you'll know quite a bit about Dr. Gross. But I just wanted to share a little bit more about him. You know, in the email, it mentions he has his undergrad degree from Wesleyan University. And did you know another notable grad from Wesleyan was Lin-Manuel Miranda, the person who created the Broadway play Hamilton. And Brian promised me that he will sing a medley of hits from Hamilton to start his presentation. So we can only hope for that. In his write-up in the email, he also went to the University of Rochester Medical School. He did his internship and residency at the Dartmouth Medical Center, where he earned the Intern of the Year and Resident of the Year awards. And I'd just like to say, from my point of view, he's truly a remarkable person. You know, he's also been a collegiate goalie for the soccer team. He was a high school hurdler. And among his many varied talent, he's also a very accomplished river runner, which I can attest to because I've been on several trips with him. And the only thing, if you ever go on a trip with him, you have to worry about is he's also an expert drone pilot. And he insists on filming you as you run through Blossom Bar. So you have to duck and dodge as that thing comes at you while you're trying to get through the rapid. And I've had the pleasure to meet his 4 children, who are just incredible, accomplished professionals. And also Nancy, who Brian is her husband, is one of the most caring, intelligent, humanitarian people you'll ever want to meet. So she's also quite a bit of the incredible nature of his family. And you know, one other thing is I want to mention a couple of patient comments. I looked up some patient comments, and here's a couple. Brian is one of the best doctors I've seen in a long time. He took his time and made me feel like I was the only patient of his day. He is amazing. And then another one, Dr. Gross is warm, compassionate, and a caring man who always takes the time to teach, answer questions, and offer reassurance. He has a wonderful bedside manner. So with that, he's going to show you his podium manner. So here he is.
Nearly 4 years here, Peter, and I've never had as gracious an introduction as that. And I'm sure Bruce Murray has many of the same bedside characteristics. I've heard marvelous things about him. I have to give credit to Peter. The only rabbit that scares me on the road is wildcat. And the last several times I've been down before I met Peter, I would wind up on the rock for several minutes. And Peter counseled me through there. And our kids learned not to do trivial pursuits against. He chose the topic of 80s and 90s, and of course they never did. He just wiped them. So give me a second to get this going. So when I finish, please remind me to tell you a neat joke. There we go. And the second thing I would say, and I thought about it, the very first presentation I gave was in Grants Pass. Bruce, what year did you were here?
I came at first of 1990.
1990, okay, well, 1982, the very first lecture I gave was back when you had 2 hospitals and 2 paramedic systems, and now this is my last lecture. So I've come full circle to Grants Pass. And what I'm going to tell you today, I'm really proud of and really excited, and I think you as a community should be extraordinarily proud. Because what happened here at the hospital and at AMR changed the way heart attacks were done 20 years ago. And it's the way that heart attacks are treated, and it all basically started from some conversations I had with some people here in Grants Pass. So we're going to talk about heart attacks, and with a nod to the Pacific Northwest and specifically to Grants Pass in the way that they have had a profound effect on heart attack treatment. So a little bit of cardiac anatomy. That's what the heart arteries look like. And you got a whole bunch of pumps and chambers and valves. And this thing beats 100,000 times a day through 60,000 miles of blood vessels. Enough to wrap any one person here, you could wrap it around the earth 2.5 times. That's a lot of plumbing. So that we mentioned Dartmouth, we actually have 4 people in our Southern Oregon cardiology group. One part right here in Grants Pass, Zach Neeson did his training. I did my training, some of my training there, and Alyssa Corley and Dave Martin from Electrophys. So the very first medical x-ray was done, and it's very subtle, but I think if you take a look right there, you'll see that this broken wrist has a little bit of deformity. That was the very first medical x-ray. And x-rays are key for what we do with cardiology. The very first electrocardiogram, you'll see what that machine looked like. You had to put your feet and hands in buckets of salt water, and the very first STEMI, ST segment elevation heart attack, was this one here, done back in the 1920s. It has this curved upper contour to it that we affectionately are called tombstone ST segment elevations, because having a heart attack back at the 20s, 40s, up into the 70s and earlier 80s was a highly fatal event. It was like having AIDS. It was like having end-stage cancer. When you had a heart attack, 1 out of every 4 people never made it out of the hospital. So I should go back. This is my EKG right now. I carry it with me. We've had a few advances over the years. The very first heart catheterization was done by this guy, Werner Hoffman, and he had this idea, since there was all these drawings of how different veins and arteries seemed to connect, but there was no way of knowing it. He wound up getting hold of a Foley catheter used for emptying the bladder. Did it cut down? He cut down on the vein in his elbow and threaded this thing up by himself. I would have passed out. And made the measurements, took an x-ray, walked up to the head of the division of medicine, who saw it, says, I don't believe it, and he fired him on the spot. But that was the first heart catheterization back in 1929. There is the x-ray of that catheter going up the arm and into the upper chamber of the heart. But this is one of my most favorite slides. This together, there's an article, you can pull it up on Google. It's called The $1 Billion Heart Attack, and it reviews Eisenhower's illness. Now, here's Eisenhower. They wanted him to run on the Republican and the Democratic ticket, the most popular man in the world, the guy who kept the free world free, defeated the Nazis. And in his third year of his first presidency, he's out in Denver playing golf and has chest discomfort in the early afternoon. He and his wife Mamie attributed it to the onions on a hamburger that he'd had. And he spent the night tossing and turning, and at 2 o'clock in the morning, Mamie called the physician who was at Fitzsimmons Medical Center and came over. And they said, yeah, it's probably heartburn. They came back the next morning bringing an EKG machine as big as one of these tables. And said, oh my gosh, she's had a heart attack. And took him to Fitzsimmons. And it was a profound effect. He had 12 hours of discomfort, kind of heartburn-like sensation. At that time, and in fact, until the end of 1970s, not even the early 1980s, there was zero that we could do to a heart attack to change the course. We could treat the pain with morphine. We could give amyl nitrite if there was a little bit of like a nitroglycerin, but that didn't change the clinical course. But then you could give oxygen in an oxygen tent. But that was the extent of it. You either lived or you died. The stock market took the biggest dump it had since 1929. They were so terrified when Eisenhower got this illness that the world shook. They brought out Paul W. White from Boston to evaluate him. He spent 6 weeks in the hospital. Activity at that time was deemed to be the culprit. So he was prohibited from playing golf for a long while. And then Paul W. White said, no, that's not the case. And Paul W. White went on the news that night and said the president had had a bowel movement. And back then, having regular bowel movements was a sign of good health. He's getting made food. He can end up having a small stroke a year or two later, from which he recovered. He had 7 more subsequent heart attacks. He had 14 cardiac arrests where his heart stopped, and they had to get it going again with the crudest and most critical, most early version of defibrillators. He spent the last 9 months of his life in Walter Reed Hospital in congestive heart failure because they didn't have very effective medicines. That has all changed. Some of the new medicines and defibrillators, he was partially responsible. The cigarette industry was very, very effective at saying it's not the cigarettes that are giving you a heart attack, it's the coffee because you have the cigarette here. And they had convinced the public for about a decade until the evidence became overwhelming at cigarette. But my line here is that the president who warned us about after World War II of the military-industrial complex was, I believe, primarily responsible for the medical-industrial complex. If this can happen to President Eisenhower, we need to do things. And at that point, pharmaceutical industry started doing research. NIH came into existence, and device plants, pacemakers, defibrillators, all of that stuff. You watch the growth. It was logarithmic after Eisenhower. So the $1 billion heart attack, a really easy 2-page read. So what are some of the major steps that were done? Well, we talked about that first heart catheterization. That was just putting a hollow tube in. Nothing was going in it. There were all sorts of ways of measuring pressures in different chambers of the heart. And this fellow, Mason Sones at the Cleveland Clinic, did the first coronary angiogram. He was actually trying to take a picture in the aorta, and the catheter whipped around and went into the coronary artery, and it visualized the artery. The young man went into a fatal heart rhythm. Unfortunately, they were able to get him right out of it. But it was that kind of serendipitous thing that said, oh, we can actually visualize the arteries that feed the heart. And they developed catheters to that effect. Dr. Grunewald was a major Boston and San Diego. He just died about a month ago. He was the father of contemporary cardiology, we should say. I trained up in Seattle with Hal Dodge, who worked with Dr. Grunewald. And Hal Dodge had a lot to do with congestive heart failure. And I put my twins there when they were young, as an example, because you can have congestive heart failure with a heart that's big and hardly squeezes. You can have congestive heart failure with a very muscular heart that is just stiff like a basketball. In fact, about 25 years ago, I published an article on a young kid who came to my office who had published as the world's biggest and thickest heart. Nothing like it. He just walked into the office one day and he had problems with congestive failure. I trained with Bob Bruce. I was his last cardiac fellow. He's the one when you have a treadmill, it's the Bruce protocol treadmill. So lots of Pacific Northwest links here. When you take a look at what a coronary care unit looked like, even through the early 70s, they were kind of open wards. You'd be there with someone coughing with his tuberculosis, someone vomiting blood, someone having diarrhea, someone having chest discomfort. And that was kind of the EKG and oscilloscope with a single lead. You take a look at what a coronary care unit looks like now. And it's a Redford intensive care unit with all manner of electrical equipment and plumbing equipment and ways to respond. When you take a look at the paramedic system, guess what the paramedic system was up until the 1960s? You took the person in the back of the pickup truck or you called the local undertaker and they would pick you up in the hearse. So I was fortunate enough to do my training in Seattle, which was the birthplace of Medic One, and my Copus, and the original paramedic unit was like that. And that had a profound effect where you could get the people on the street. Two types of heart attacks. Plumbing heart attack is I'm going to be talking about where one of the arteries blocks off. And if I put a blood pressure cuff up on your arm, we do that every day in the office. Well, what if we left that blood pressure cuff up on your arm after about 5 minutes? From an unhappy camper. And what would happen to that arm if we didn't let the blood pressure cuff down after a day? We'd have a dead arm. And that's what's happening in the arteries that feeds a portion of your heart. The other type of heart attack is the electrical heart attack, where just suddenly, a person passes out because their heart goes into a irregular rhythm. And that can happen as a consequence of the plumbing, but we're going to be talking primarily about the plumbing heart attacks today. And then, of course, we have AMR and Mercy flights to cover Jackson and Josephine County, and, fixed wing helicopters, ground transportation, all manner of citizen CPR. Major advance in the 70s, primarily with basic life support, and that. Then we have important. Albert Starr did the very first valve replacements, and then they have taken off, and now we do more valve replacements rather than opening the chest. We put the new valve into the groin using a heart catheterization technique. We do more of them than we do open heart, just down the iconic. So this fellow also from the Oregon Health Sciences Center. You can look in his eyes. He was a wild man. And Charles Daughter he was a radiologist, and he had this idea. He looked at autopsy material and arteries and the legs were blocked. He said, well, if they're blocked, let's unblock them. And he used all manner of experimentation with different wires, piano wire, coat hangers. And he would sterilize them, and he would practice on cadavers initially. And then the very first case where they did it, he had an 82-year-old woman who had gangrenous toes. And she said, there ain't no way I'm going to have surgery. And he said, well, let me try and fix it. So if you look there, it's a tight blockage in the artery going down her leg. It's not completely blocked. And he just basically put one of these wires down and stuck it apart. And he got enough blood flow that her gangrenous foot healed. And yeah, she lost some toes, but she was then still in his book. So that's another Pacific Northwest. Melvin Jokins. He was training with Charles Daughter, and he was up there when he developed the catheters that we use today. Probably 80% of the time you go in the Jokins catheters, and if it doesn't quite fit the artery, we use some new variations of it. But another Pacific Northwest. So when you take a look at Steve Jobs' thing, creation is messy. You get genius, you get madness. Sometimes they're both sides of the coin. So now we're going to move into the late 1970s. This guy, Andreas Kunze, had this feeling, well, it's one thing to kind of open a stagnant artery to the leg. I mean, the thing doesn't move, okay? The heart is 100,000 beats a day. When they're doing these heart catheters, they're threading a needle through a moving needle, okay? So it's a little bit tricky. But he had this idea that, well, why don't we make a balloon and try and open up an artery if it's partially blocked? And everybody thinks that the surgeons wouldn't touch it. But he and his wife and his nurse made these on his kitchen table, these very crude things. And he finally convinced the surgeons to let him get a shot at it before they did open heart. So they had to go in the open heart surgical table. They did the angiogram and they found that he had a very tight blockage right there, still had flow going down the artery. And then he put his balloon across and he squashed it open and got a really good result. And that was in the 1970s. And then he was spirited away to Emory Medical School where my son went. And every year he would have a conference. We were learning more and more and more. I'm sitting over here somewhere behind Dr. Soames, learning about the new technique in 1983. And unfortunately, he died in a plane accident in 1986. Physicians don't always make the best pilots. So we're talking about stent. What is ST elevation myocardial infarction? If you take a look at this artery right here, the right coronary artery, and do an injection, it'll look like that if it's wide open. If you have a partial blockage in it, it could be due to some fixed plaque or a sudden rupture of a plaque and bleed into it. And you can see blood still gets across, but it's compromised. What a STEMI is when the blockage goes to a complete obstruction. The plaque is disrupted and the body tries to repair that crack in the plaque. And in the process of trying to repair it, it makes too much blood clot and it occludes the vessel, just like having the blood pressure cuff not let down. And you get very characteristic EKG patterns. There's those tombstone ST segments that tells me this person's got a complete blockage to the artery that goes to the bottom of the heart. And this is what it looks like after we open it up. We put a stent across it, deploy the stent, then pull everything else out and reestablish flow. And the key is to get that done quickly. Well, Ward Kennedy was my boss at the University of Washington. We had no idea what actually caused a heart attack until some aggressive people started saying, let's do an angiogram during a heart attack. Up until that point, it was considered foreboding. It was said that if you had a heart attack, never, ever, ever, ever put a catheter in the heart and take a picture for at least 6 months. It was dogma without data. And Ward Kennedy says, I think we need to take a look. We started taking a look. And if you got them within the first couple hours, the artery was completely blocked. And they had a blood clot dissolving medicine called streptokinase at that time. And I was a fellow, and then ultimately I was a year on staff as an assistant professor. And we did the very first trial where you'd get a person who'd have a heart attack and you'd have to call up a cath lab team because there was no need to have an emerging cath lab team to try to cobble it together. It would take several hours. And you'd go on in there and you put a catheter into the beginning of the artery and you dribble in a little bit of blood clot dissolving medicine. And about 60–70% of the time it might open it up. And for the ones that had opened, they had a better survival rate. So it was a very first treatment, medication or device that changed the outcome for the people that got it was a randomized trial. And the people that got it actually did better. More of them lived. So fast forward, this study was published in '83. I arrived in Medford in 1982. Young, rash. Oh, I think we've got a great new way to treat heart attacks. This is the very first heart attack treated by this in all of Oregon. A 42-year-old fellow who came into the emergency room during a weekday. I happened to be on call, and the lab was open. I said, let's take him to the lab. I called the pharmacy, said, give me some streptokinase. And there you can see, here's the catheter going up from the groin, round by the neck, and we're injecting some dye down the artery, and it's completely blocked. when you have a heart attack on the bottom of the heart, you frequently get very low blood pressure, very slow heart rate. So I had to put a temporary pacer in to keep the heart rate up about 60, because it was down around 30. And he was nauseated, hypotensive, and the yellow color of the wall was really sick. And I would then, and the clot basically would be here, and this whole part of the heart is dying, and the clot is made up on an electron micrograph and stuff like that. And after half an hour or so, I'm injecting this stuff down a milliliter at a time, and I do an injection, the clot wouldn't dissolve, and finally, after about 40 minutes, it opened up. Now, that's not a very wide opening, but even a trickle of flow will reestablish, and if you've got that blood pressure cuff up on your arm, and it's hurting like crazy, then you let the blood pressure cuff down, and what happens? You just feel life come back into your, the trick is you gotta do it quickly, so that the muscle doesn't die. Anyway, as soon as it started getting flow, we were able to turn the pacemaker off and pull it out, didn't need to give him medicines to raise his blood pressure. But ideally, you'd like to take an artery that's blocked like that and make it wide open, and this all has to be done just as quickly as we can. And so there are places now, actually, for Grants Pass and us, all the way through the early 2000s, you got scooped up, taken to an emergency room, and you got that given intravenously rather than in the cath. And we thought there was a better way to do it. In fact, my favorite way to dissolve the clot is to put a piece of cobalt chromium or stainless steel in there. And here's the area that we cover, the state of Jefferson. Southern Oregon Cardiology covers this in the esophagus. And if you're in the green area, Josephine, Jackson County, and the northern part of Siskiyou County, you're within 60 minutes usually. It's 1,000 square miles. And we have teams set up of first responders to get us there, get you to the hospital. If you're in Los Angeles, they have 34 STEMI systems, and our statistics beat theirs in terms of getting the artery open, even when you have to come from AMR, bringing you directly down I-5. We have a very well-defined system. Here is that system. We ran a heart cath conference. I used to run it every Wednesday morning since I got here in 1982. And we would bring together all the cardiologists, two separate groups of cardiologists, and we talk about challenging cases or interesting ones or educational ones or map out where we needed to go. And we just got tired of having folks coming from Grants Pass who would go to the emergency room, get thrombolytic therapy, and it would work, but only about half the time. So in the meantime, the heart artery remained blocked, the blood clot wouldn't dissolve, and after 4 hours, the ER would say, well, we need to send them down, and then they would send them down, and sometimes it would have finally opened up, or we'd have to use a balloon to try and open it. But we noticed that if somebody walked into the emergency room with a bad heart attack during a weekday, and I quickly took them to the emergency room and put a stent in, boom, they felt better right away. So we decided we were going to try something that was against the prevailing winds at the time. We were going to set up a program where everybody in state of Jefferson, Jackson, Dustin County, and Northern Cisco, if they had a heart attack, we're going to get that artery opened with a stent. That meant that if you walked into Three Rivers Hospital, the first call was to AMR. The second call was to me, because we are never closed first for heart attack because of the high mortality. If you were picked up by AMR in the field, rather than what's happening everywhere else in the country, rather than going to the closest hospital ER to get a blood clot dissolving medicine, they'd call, they'd admit it at 2 o'clock in the morning. Gross, we've got one, looks like an anterior wall infarction, we'll be there in 35 minutes. Cath lab crew is activated, we meet them at the ambulance bay, jog on down to the cath lab. The person can't give much of a history, the spouse gives even less because they're so terrified. And you take them right into the lab and you open it up with and so we put together this system. We get a mission statement to facilitate the accurate rapid diagnosis, treatment, transport of patients with a STEMI throughout the area to Rogue Valley Cath Lab for immediate stenting. A novel approach. Until then, at that time, the approach around the country was if you had chest pain, The paramedics scoop you and take you to the closest ER. You get a blood clot dissolving medicine that works half the time. Now, the paramedics were educated and entitled to activate in the field, activate the cath lab, and come roaring down I-5 to get you there. We became a single cardiology group in 2010, about 7 years after we started this program. We had 4 other hospitals involved. Now, 3 Rivers at that time had just joined Asante. That was in 2001. They did that. Paul Yonke was the. I talked to Paul, and he said he'd be willing to send patients. I talked to Dave Matthews from AMR. He's part of a national ambulance. They have national protocols. This is the way you scoop and you go to the closest ER. Dave and I were able to talk to AMR corporate, and they said, "Okay, give it a try, but it better work." And we talked to Providence Hospital. We took Ashland was a separate hospital, Fairchild separate hospital, different CEOs. They were all willing to let us try this, even though we were moving against what was the prevailing way of taking care of a heart attack. We had all of these first responder groups, had to educate them on how to do electrocardiograms and activate an appropriate EKG. We have hospitals on the coast, hospitals in Eastern Oregon. They're too far away. They get the traditional way of getting a blood clot dissolving medicine, and then they get airlifted over for more definitive treatment. So here basically is that state of Jefferson. Here is Asante Road Regional, and we have hospitals on the coast, ER, Fairchild, we have 3 Rivers, we have Providence, Fairchild, even Mount Shasta, Lake District Hospital, Klamath, and Roseburg. They send us patients. We kept track of this data, and this is overwhelming. Every year in the 1990s to early 2000s, Rogue Valley Hospital was labeled a top 100 hospital for heart attack death rates out of the 6,000 hospitals in the country. And it was through a combination. Sometimes we balloon it, sometimes we'd stent it, sometimes we did thrombolytic therapy. We had an 8.6% mortality rate compared to the rest of the world. The rest of the world had 12% mortality. That difference is huge in medicine, especially when you're one of those 4%. Yeah? We kept track of our statistics. For that first year and a half, we did every step because we knew that every place was going to send it to us, paramedic was going to bring it. We had a death rate of 2.1%. If you walked into 3 Rivers, Providence or Fairchild or Ashland, it takes about an hour to get you out of there. We get you out now in 20 minutes because we've got such a great team. But rather than getting the blood clot dissolving medicine, they call the ambulance and bring you on down. The death rate was 4.3% if you walked into an ER. Called 911, the death rate was down around 2.1% for the whole area. But watch this. If you walked into Rogue Valley, 37 of the patients did, 0 died. But here's the thing, watch this. 81 patients called 911 from in Medford or in Grants Pass or in Ashland. And every one of them was activated directly to the ER and directly to the cath lab. 0 out of 81 died. So I hung on to this. I didn't realize kind of the implications of it until I ran into Doug Weaver, who was head of the American College of Cardiology, trained under him up in Seattle. And I showed him the data. He was a big blood clot dissolving man, and his jaw dropped. He says, "You have to publish this data." So we published it. And it caused a minor stir. What are you guys? You're not a big facility, you're not a big major educational thing, but some people took light note of it. A couple months. So basically, this was a heretical approach to the treating heart attacks. And it basically started primarily because most of our patients came right out of 3 Rivers or came right out of AMR. If you weren't in the Jackson County. Paramedics was the heretical concept. You would diagnose STEMI, bypass the closest ER, go directly to the where people say this can't possibly be done. There's too much risk. It's not going to work. It worked. A couple months later, I was invited to Hart House in Washington, D.C., and Duke University was putting on an acute conference on all aspects of acute heart attack and arrhythmia treatment and congestive failure. And the opening line of this conference, it still gives me chills. We need to change the way we treat heart attacks. We need to do it the way. So.
We might stop. Okay.
It's gone.
Who was right?
I know. Yes. Yeah. Punchline.
Much like, okay. So the opening line from this big conference, we had people from Mayo Clinic, Cleveland Clinic, UCLA, UW, Duke University, Duke put it on. The opening line of the conference was, we need to change the way we treat heart attacks. We need to do it the way they do it in Southern Oregon. And that started an emphasis around the country. All sorts of hospitals started to try to do it. They included us in the protocol. There were big hospitals, medium-sized hospitals, and small hospitals. And indeed, if you had paramedics activate and you avoided diverting to an ER where you'd only get blood clot thinners, it worked. Here, this guy Spencer King was the most renowned interventional cardiologist at the time, and we published the article. And that changed the way things were done. That's about 2010. We've been doing it since 2003. Historically, for 1980, so in the 70s, 60s, and 50s, Eisenhower, 25% of people never left the hospital. Then you had coronary care units. Coronary care units and some intracoronary thrombolysis. Death rate drops here when people start getting intravenous because you could give it in an emergency room. But here's the death rate now across the country. It was from 2003 in Southern Oregon. The rest of the world started doing it in 2010. And that's the way heart attacks are treated. And if you take a look, here's people who walk into the Three Rivers emergency room. Here's people who call 911 in Josephine County. Here's the Medford Jackson County group, and then a number of other hospitals with small, a huge chunk of people right out of this community. So let me show you my most favorite case. This came out of Grants Pass. It was a young, pretty healthy 51-year-old man who was having breakfast in one of these establishments here in town. And right in the middle of breakfast, got the most horrific discomfort, turned pale, nauseated, just looked like the wife, threw him in the car, and then called 911. It's all right. She raced to Three Rivers, where they did an EKG and made the diagnosis of an acute inferior. It's going to be one of these right coronary arteries, almost certainly, and got him in the door, out the door in 22 minutes or so, 23 minutes, which is about 30 minutes faster than most other ERs around the country. AMR immediately whisked him into the cath lab down where I was waiting. We brought him down the hall. They're anticipating there's going to be a blockage in this artery. And here's the injection. You inject it, and boom, it just stops right there. That's the artery with the plaque that's ruptured and blood clot completely closing the artery. And he's in distress. I mean, he's nauseated, had terrible chest pain, blood pressure issues. And what we do is we put a wire, big as your hair, we steer it down the artery, poke it through the blood clot into the distal vessel, and then we measure the artery and put in a balloon stent. Stent is collapsed, very low profile, looks like the ball head, slide it over the wire, and then we deploy it by blowing up the balloon. Yep.
That's exactly what you did with my husband in 2008.
Really?
And we're on the paperwork.
I'll talk to you later.
Yeah. He's dead.
And then here it is when we're done.
Wow.
Look at the size of all that muscle. We got it so quickly, there was very little death. So the heart, as soon as you cut off the blood supply, it starts squeezing in that area of blood supply. And then it now is permitted to recover if you can get it done within a matter of minutes. So we got that artery done. Now we're going to take a look at the other artery over here. Oh yeah, 65 minutes from the time they walked into Three Rivers emergency room to the artery was open, and you guys just kind of went over that. It took me 45 minutes to drive up here. So that's a cooking grease situation. We really know how to do it here. So here's the picture. Normally we take pictures from all different angles. Here is the picture of the other artery. And I'll just tell you, the other arteries are wide open. But what's going on there? In a younger day, this young man had gotten in the way of a shotgun. So you never want to miss an opportunity to market your program. STEMI. Get the lead out. And so this is my friend Ivan Rokas and I have published a bunch of articles on heart attacks, but this process of putting a stent in an artery is the most complex, time-sensitive therapeutic intervention in the world of medicine today. Us is measured in minutes. Mortality is key, and teamwork and transition is absolutely essential. These are all the things you have to think about while you're taking care of that patient with a dearth of information, but knowing what you need to do, what the anatomy is, what's causing the obstructions. And we got lots of different kinds of catheters now. It's like we got all sorts of different ones. Let me show you what an artery looks like. If you give me about 2 minutes here, okay? So here is we actually, when we're done, here's a wire down the artery. This is a virtual, we're pulling this catheter back over the wire and looking at the stent that's inside to make sure that the stent is fully deployed, that we don't have to put a bigger balloon in at some other area. It's just incredible technology. And to tell you how we do compared to the rest of the country, the further to the left you are, the better you are compared to all of the other places in the US. We are probably in the top 5% for mortality for heart attack patients. You know, we're not a big UCLA or University, but even despite servicing a huge area, our death rates are better than the rest. And if you were having a stent put in, but you weren't in the middle of a heart attack, just had bad angina, I think we're probably, our mortality is in the top 2%, it looks like. And here's a patient who has had advantage of all the things we can offer these days. They had obviously open heart surgery, you can see from the wire, and they probably had this clip placed on the left atrial appendage, a mitral valve ring to take care of microleakage. And sometime later, they needed a pacemaker. And then sometime later, they needed to have a stent in one of their arteries. And then sometime after that, they had a valve replaced. This person probably has done 30 years now, functional, not spending the last 9 months of their life in Walter Reed Hospital. Wow. Medicine is changing incredibly quickly. Every 73 days, back in 2020, I suspect it's probably every 40 or 50 days now, the amount of medical information doubles. You can't possibly read that and keep up with it. Listen, I'm talking about this. It's just, you need computers to help you. And finally, you know, our awards for heart attack. We've got lots of awards. They're always in the top 2. So anyway, it all started right here. I think Delivers and AMR probably were our biggest supporters of the one, and it changed the way heart attacks are treated around the country. They're using the same thing we developed in 2000.
Yeah, thank you. I mean, what can we say? How proud I mean, I had no idea. I did know that we were in the top 100 hospitals because we used to get US News and World Report, and my husband has been over that hospital numerous times. So yes, we are very thankful for what we have. And yes, how things have changed. Yes.
Docs and nurses down there and up here. It's a team effort.
Yeah, and boy, we appreciate what you've done and what you've made us into. So I can't thank you enough. And with that, I'm gonna have Allison come up because it's our Sergeant of Arms. And so she's our Sergeant of Arms today.
Hi, everybody. That in there. I'll be brief. Our time is limited. But today I was thinking about what I was going to talk, and I didn't know. I looked up, different days, the national days, things like that. Nothing was really catching me. And then I looked down at my counter, and I saw my speeding ticket that I just got weeks ago. I took Calvin down to Medford. We had a great day. We went to Comic-Con. He's the nerdiest kid I've ever met in my life. He loves Comic-Con, so I took him down there. And then we get in the car, we're heading back to Grants Pass, and he immediately says, I have to go potty. So I am speeding through downtown to make it to Target to take it to the bathroom. And all of a sudden there was a big flash in my face and they had gotten me with the camera. So it made me think of all my past speeding tickets. And I've been so good the last few years. Like it's been a few years since I got one. But when I was in college, I would have been probably about 19. I had lived in Phoenix, Oregon, so I went to SOU. And that was the same time that they were building that nice fancy overpass that makes no sense and it crisscrosses. And they had to pay for that somehow, and I think that I single-handedly helped pay for that. I made really good friends with one of the cops in town. He had pulled me over 3 days in a row. Same cop. But I only got 2 tickets out of the 3, so I counted as a win. But anyways, thought I'd tell that story because I think there's a lot of people. When I got my ticket, I brought it back to work and I was all mad and I have to do traffic school. And it seemed like everybody had some sort of funny story, whether they got pulled over, they got a ticket. So that is what I thought we could do today. So if anyone has any funny stories about getting a speeding ticket. Jay's got a mic.
Story, Jenny, I'm sure you have a story.
Probably not to drive with her.
It's so good.
Hello, everyone. I was an independent sales rep in Southern California for a number of years. And so I was on the road a lot. And I got speeding tickets often. And I got a letter from the Department of Motor Vehicles that said, "Dear Ms. Toronto, driving is a privilege, not a right." It cleaned up my act.
I have a quick funny one. When I used to live in Salem, I went over to the beach once in a while and I remember being somewhere and driving past the Dairy Queen and thinking, oh, I have to have, a soft serve ice cream cone. So I got this ice cream cone and I'm so excited about it. And I look up and I've just run through a red light and there's a cop behind me and he pulls me over and I'm still eating my ice cream cone. And I was 60 or so and he was a kid and he said, you ran the red light. I said, yes, I know. I was just so excited about my And he said, oh, you seem like a really nice lady. I'm just going to give you a warning. So that worked out.
I also had one of those where I had to go to the bathroom between Medford and Ashland, and I was zooming down to the rest area on the side, and the police followed me into the parking lot. I got out of the car and I said, I have to go right now. And the bathroom, I came back up. I said, I am so sorry. And he said, it's okay. Have a good day.
Or we're supposed to remind you to tell us a joke. But I promised Dawn we'll get the mic next. I don't have a joke. All right, this is almost more of a question. I happen to know that Dr. Gross would go to work in his Segway. And for the Carpenter Award, he had won one year. And when he came in to accept the award, he came in on his Segway. So Dr. Gross, did you ever get a speeding ticket?
Maximum speed is 12 miles an hour. Because you go way fast. Never saw it, but just the other day, I still have it. A joke. Okay, so this is kind of probably oriented towards Steve Rowe. So, you get the new car and they give you this long list of things where you got to get your car to maintenance and stuff. And so take the car in for maintenance, and the guy comes out, he changes the transmission fluid, the oil, and checks the spark plugs and all that. He's wiping his hands from the grease, walking out, and gives me the bill and says, Doc, okay, you and I do a lot of the same kind of things. Fuel lines, valves, engine power, okay, inflation, balloons and stuff. How come you get paid more than you get? They said, well, it's 4 years of college, 3 years of fellowship, of residency, 4 years of a specialty additional training. Try fixing it with the engine running.
Yeah.
Okay, back to the tickets, when I was in high school, a group of us decided to skip school one day, I mean, more than one day, but this one particular day we did, and it was wet, and I was driving too fast and crashed my car into a little building alongside a little storage building. And everyone, we were all fine, and another group of friends came and gave us a ride back to school, because, you know, no cell phones back then. And so I had to call my parents and explain that I just wrecked my car at 11 o'clock in the morning. So we all go back down there to, you know, kind of pull it out and try to tow it, and when the police had arrived by then. It was apparently not supposed to leave the scene of an accident. But, yeah, my stepdad was so pissed, and that the policeman opted not to make the ticket, and thought I was maybe in enough trouble.
Any others?
So Larry had five-way bypass in 2005, and I was down at the hospital. Dr. Hall was gonna do the surgery the next day. I was taking care of my dad. And he had very little diabetic, and he had to have somebody with him all the time. So I had to get him to ready to my sister. And so I got a ticket going through Ashland at 85 miles an hour. Get him to my sister's before dark. I had to pay.
This is about the legal aspects after getting a speeding ticket at a speed trip, where I was caught on radar, supposedly, according to the officer. Yeah, allegedly. And so I had, like, I don't know, 3 or 4 weeks to go before I had to go to court. I did all kinds of research about the accuracy of radar technology and getting correct speeds. And I brought with me to court a diagram, like a vector of how the radar might be looking and where I was and where the cop was and how I couldn't have been going 45 in a 20-mile-an-hour zone. And the judge said, well, that's very interesting. Thanks very much. The fine is still 95 years.
I was stationed in Germany. And when I came back to the United States, I had my motorcycle that I raced in Germany. This is 1975. So I'm looking across Kansas, I'm being stationed in California. And I'm doing about 95 on the back road. And so I come over a crest, and when I'm starting to come down, the car coming towards me, the lights come on, and a hand comes out pointing to the side of the road. Oh, hell. I cranked that bike up and I'm going. I mean, he's got a radar. It means he's got, you know, his microphone. I mean, so I went and pulled over the side of the road, laid my bike down in the grass. And I'm laying there, and finally I hear him go by. Whoa! I got up and made myself a peanut butter sandwich. I cruised to the next town and I'm driving. I go through the town and there's 2 cop cars parked in a parkway, and they looked at me, they followed me through town. I get on the interstate, 1 cop car stays with me. About 20 minutes, he's right on my tail. And then finally that state trooper pulls alongside of me, looks at me, I wave at him, and he pointed his finger at me, and then took off. I think that fortunately I had my US license plates that said I came from Germany. And so he just let me go, but all the way through Kansas was.
It feels like you can get off and run beside it.
Okay, oh, I'm, Tom has one to share, and then we'll go from last to here. Yeah.
I was in, yeah, don't speed. I was in Salem riding my bicycle, not motorized like they all are today. And I came to a stop sign And I was in the gutter on the far right as you're supposed to ride, and I failed to stop I made a right turn. And there was a guy, a policeman on a motorcycle behind me, and he just kept following me, and I wondered why. And he ended up pulling me over and giving me a ticket for turning right on at a stop sign, and I couldn't really, I still to this day do not understand why you would need to stop if you're over in the gutter. Bicycle. So I went to court and I was found guilty.
I'll just say, my husband also got a bicycle speeding ticket when he was in high school. And of course, they didn't catch him, he didn't go in and pay it, whatever, somehow he didn't go, he just forgot about it, he says, a stupid bicycle, I'm not gonna go. Well, he was on a date to the prom, and he got pulled over with his girlfriend he was so excited about. They left him, his his parents had to come get him because they took him away to jail. Like his bicycle tickets. So I mean, my husband has got some of the most crazy ticket stories. And now, of course, he has FBI clearance because he was a builder and he built the FBI. So now they don't do anything. Every time he gets pulled over, they pull up his record and they say, oh, you could go. So wow, yeah, that guy's got tickets galore. Anyway, great stories. Thank you very much for that. We do have 8 of clubs.
And a quick reminder to put your happy bucks on the table if you don't.
Yeah.
Make 50 sad bucks for speeding tickets.
Yes, exactly, yes, and if you're just happy, we're welcome to walk the so thank you very much. Anybody have to 8 clubs? We have a winner? I know, Lisa's not here, gotta have a winner, I guess it's a diamond. Oh, packet?
I sold all the cards and that was $51.
Okay.
I have here.
The one card. Well, I think there was another one here. The next winner is a private club. So obviously the clubs are lucky. Do we have a private club? Yes. Okay, Bev. Okay, I know. I always get spades and clubs mixed up, but I thought I was pretty good. Okay, Bev, you are our winner today. Thank you, and thank you for staying up. I do want board members to know that we did not cancel the meeting next Wednesday night for the board. It's at All Fair Health. Please let me know if you can be there soon, because we have so far, I think, 3 or 4 people who can't be there. So with our board right now, we need 9 members, so we need to know who can be there next Wednesday. I'll send out an email. And meanwhile, the heart reminds us that despite differences in language, religion, or culture, we are all bound by the same longing for love, belonging, and dignity. With that, have a great week. We'll see you on Saturday. May 3 tomorrow, Juneteenth.
Juneteenth tomorrow.